Hello, my name is Paul Banaszkiewicz. For the next half an hour or so, I'll be taking you through inflammatory conditions and connective tissue disorders of the hip. The four most common types of inflammatory disorders are rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and SLE. The connective tissue disorders are more straightforward in that I'm just going to cover the two most common ones, which are EHLERS-DANLOS syndrome and MARFAN syndrome. We'll start with rheumatoid arthritis because this is the most common arthropathy, affecting around 1% of the population. It's an important topic for the exam, and there are, in essence, two parts to rheumatoid arthritis. There is the basic science of rheumatoid arthritis, covering the general basics of the condition. What is rheumatoid arthritis? What is its etiology? How do we manage it? This is by far the most important part of rheumatoid arthritis, as this discussion cuts across so many parts of the FRCS Orth exam, whether it's clinicals or viva, a clinical case of rheumatoid hand, rheumatoid foot and ankle, rheumatoid shoulder. You'll always get something about the general management of the condition and what causes it. Also in the viva, it again cuts across many viva tables. The second part deals with the specifics as relates to the rheumatoid hip. This is the one I want to focus on because that's your term, the hip term, and that's what we're about with the lecture. However, I wouldn't necessarily say the rheumatoid hip is an A-list clinical topic. It rarely, if at all, is used as a short case. It's much more suited to an intermediate case, but even then, it's not top of the list. Osteoarthritis and osteonecrosis much more frequently get brought in for an intermediate case. It's probably more important as a viva topic, particularly how to manage the painful end-stage rheumatoid hip that needs a total hip arthroplasty. There are many things to discuss and some complex issues that candidates need to be aware of. So what is rheumatoid arthritis? We'll start off with a definition. And there are various definitions of rheumatoid arthritis. Just learn one. There are lots of vagaries, semantics about what's going on with the disease process, and you can get bogged down with lots of different readings in various books and articles. But just ignore this, have a clear, precise definition. It's a symmetrical, erosive, deforming, inflammatory polyarthropathy involving both small and large joints. How is rheumatoid arthritis diagnosed? Rheumatoid arthritis is diagnosed by the presence of 4 out of 7 diagnostic criteria that have been established by the American College of Rheumatology. So more specifically, morning stiffness greater than 1 hour for that greater than 6 weeks, swelling of at least 3 joints for greater than 6 weeks, involvement or swelling of the wrist or hands for greater than 6 weeks, bilateral symmetrical polyarthritis for longer than 6 weeks duration, the presence of rheumatoid nodules, positive serum rheumatoid factor, and radiographic changes that are typical of rheumatoid arthritis. You may be asked about radiographic changes. It's a very simple question, but it comes up quite a lot of the time, and you do need to be aware of this. The key differentiating features with rheumatoid arthritis are that there are no osteophytes are present, marginal erosions, and osteoporosis. The etiology of rheumatoid arthritis is still unclear. It is thought to be a disordered immune response that causes an inflammatory response against the soft tissues, cartilage, and bone, involving antigen-presenting cells, T helper cells, natural killer cells, and plasma cells. The autoimmune mediators of tissue destruction include macrophages, lymphocytes, and plasma cells. There is an environmental trigger which is superimposed on a genetic predisposition. This slide deals with the immunopathogenesis of rheumatoid arthritis. A likely hypothesis for the chronicity of the inflammatory process is a persistent foreign antigen, perhaps a bacterium or a virus, that is taken up by a macrophage but is not destroyed or removed. This leads to a systematic inflammatory reaction mediated by the immune system and characterized by inflammation of many joints, vasculitis, and granuloma formation. The buzzword is molecular mimicry, and that's a nice one to use in the exam if you're able to do so. Rheumatoid arthritis, moving on to the general surgical aspects and orthopedics. Over a 30-year follow-up patients, 30-year follow-up period, around half of all rheumatoid patients require rheumatoid-related surgery. The major game changer has been the introduction of biological disease-modifying anti-rheumatic drugs in the last 10 years. And various studies have estimated that this has resulted in a 40% reduction in the need for total hip arthroplasty. So that's very significant. It's even more significant for total knee arthroplasty, where the studies suggest even greater reduction. However, you're still likely to come across patients requiring total hip arthroplasty, end-stage rheumatoid disease, and there's lots to discuss about the management of these patients. My concerns as an orthopedic surgeon regarding rheumatoid arthritis are the polysystemic, polyarticular nature of the disease, polypharmacy, as patients often take a variety of medication that can affect surgery, the immunosuppression that's present, either from the disease itself or by their treatments with medication, which increase the risk of surgical site infection, difficulties with rehabilitation. I need to check for neck symptoms, rule out cervical instability. My anaesthetist will be very keen if he's got to do a GA that there's no neck issues. I need to inquire if the patient's on any biological therapy that will need to be stopped prior to surgery. The bone quality is usually poor, secondary to the disease process and medications such as steroids. The younger age of the patient at the time of total hip arthroplasty leads to greater functional demands, increased longevity requirements from the implant, and higher expectations from surgery. And if you have a juvenile chronic arthritic patient, the anatomical variations such as protrusio, excessive femoral anteversion, anterior bowing, and underdevelopment of the femur are challenging at surgery and may lead to some difficulties if I've not thought through the surgery and pre-planned this beforehand. For a 5-minute intermediate case history, there's a lot to cover, and you've got to be practiced in this so that you're able to get through the material as fast as you can. Patients will usually present with a chronic progressive groin, buttock, or thigh pain. There may be medial knee pain that's referred from the hip, a deterioration in mobility and ability to perform activities of daily living. Inquire about the disease onset, the pattern and sequence of joint involvement, the pain, its site, severity, and radiation, any morning stiffness, and if so, duration, and functional difficulties. The disease is subject to acute flare-ups, but it's important to try and differentiate that there's no femoral head collapse that's occurred secondary to AVN, no fractured neck of femur that occasionally can occur, and very infrequently a septic arthritis. Don't forget to inquire specifically about the medication the patient's on and the disease control, how often they're seeing the rheumatologists, and are the rheumatologists happy with disease control at present, or is there been a flare-up and medications had to be increased? Social circumstances is important. Don't forget about smoking, alcohol history, and any previous anesthetic and surgical history. Inquire about extra-articular manifestations of rheumatoid arthritis, or else you will lose a mark. These are, have you got rheumatoid nodules? There could be dermatological issues, ocular, cardiac, renal, pulmonary conditions. I think then of the two syndromes, which are Felty's and Sjogren's syndrome, and then finish off asking systemic features such as any weight loss, fatigue, or anorexia. Standard hip examination, please look, feel, move. Stand the patient up and inspect, look, get them to walk. There may be some deterioration in walking ability recently, so that's important to inquire about and check for, because it may be the presenting feature of a slowly progressing cervical myelopathy, which will need to be investigated prior to total hip arthroplasty. Trendelenburg test, be careful with this. It needs to be done very slickly, but the patient may have significant hip disease, and it may be difficult for them to perform this, so don't persevere in this situation. Likewise, supine examination, palpation, Thomas test, range of movement, special test, and neurovascular status. In more detail with the clinical examination, shake the patient's hand, look at the skin for its condition. Is it dry? Is there any eczema present? Is there psoriasis? Is it rheumatoid arthritis? Could it be psoriasis? Are there any scars from previous surgery present? On general inspection, a patient will usually have features of extensive rheumatoid disease affecting many joints. The buttocks and thigh are markedly wasted, with a limb held in external rotation and possibly a fixed flexion attitude. The skin overlining a joint may appear shiny, thin, atrophic, with evidence of spontaneous bruising. Again, we've mentioned Trendelenburg test. Be careful, it can be uncomfortable and painful for the patient. Don't let them fall down in the exam. It's not a good idea. You will lose marks. You may fail the case if this happens. All movements of the hip joint are restricted and painful. It's important to examine the upper extremities to evaluate the patient's ability to use a walking aid. The shoulder and elbows are often involved in rheumatoid disease. The knees, ankles, and feet should be examined for arthritic involvement. A full upper and lower limb neurological examination should be performed if you're suspecting cervical myelopathy, and look for any walking aids, footwear, or braces. With discussion, you may be asked about investigations for the patient. You want to perform a full blood count using these LFTs, chest radiograph, and a lateral cervical spine flexion extension view if one has not been done recently. AP pelvis may show a segmental avascular necrosis present, maybe large cysts in the pelvis or femoral head, and these are so-called goodies. You don't see the subchondral sclerosis and osteophytes that you see in osteoarthritis unless secondary osteoarthritis has developed. Urine dipstick and culture to exclude occult infection, pulmonary function tests with patients who have lung disease, and an echo if the patient has cardiac disease. In broad terms, you may want to discuss goals of treatment, especially if you start to struggle. And it's quite nice just to say my goals of treatment with rheumatoid disease would be reducing pain, control of disease activity, maintaining daily functional activity and work, surgical reconstruction, and maximizing quality of life. Management of the severe rheumatoid arthritic hip requiring total hip arthritis, the end-stage rheumatoid patient. You may need to discuss which mode of fixation to use, whether it be cemented, hybrid, or uncemented, what bearing surface you're going to use, how will you consent the patient for surgery, the complications from surgery. They are known to have an increased risk of surgical site infection. The revision rate has traditionally been thought to be higher than osteoarthritis, but recent reports suggest similar rates. And how are the results compared to osteoarthritis? What are problems like an Oxford hip score? So management of these patients, the rheumatoid patient will usually be generally disabled with skin fragility, osteopenia, vasculitis, and poor musculature. It's important to ensure the patient is in as fit a state as possible for surgery. Synovitis should be as well controlled as possible with no chest, urinary, dental, or skin sepsis. Anesthetic risks should be looked at. We mentioned cervical spine, cardiac problems, pulmonary all these should be excluded. The cervical spine you can narrow down into, has a patient got any neck instability symptoms? Are there any symptoms suggestive of cervical myopathy? When will you get new radiographs of the neck? Usually if radiographs are older than 6 months or a year, or there's been some new neck symptoms. When will you perform an MRI scan of the cervical spine? What will you look for? Things like space available for the cord. And when we refer on to a spinal surgeon rather than going straight ahead with total hip arthroplasty. Recently, it's been recognized that patients with rheumatoid arthritis treated with biologics have an increased prevalence of staph aureus nasal colonization, around 40%. So perioperative decolonization protocols are particularly important with this group of patients to reduce the risk of surgical site infection. A get out clause, if you're struggling and the examiners are cornering you, is to say that you'd like to approach the patient in a multidisciplinary team approach involving specialized nurses, occupational therapists, and physiotherapists as an invaluable source of advice and education. The medical management of rheumatoid arthritis may be discussed, particularly the biological, if the patient's on biological medication. These usually need to be stopped for a couple of weeks before operation and then restarted 2 weeks afterwards. Stopping methotrexate can increase the risk of associated disease flare-up and associated complications, so it's generally recommended that you continue with methotrexate. The classic paper to mention is Grinnell et al. From 2001, Annals of Rheumatology Surgery. It was a prospective randomized control trial of 388 patients with rheumatoid arthritis, which demonstrated no increased risk of surgery from elective orthopedic surgery. Operative issues itself, you need to ensure that there's careful positioning on the operating table. That's vital due to the poor skin present and other painful joints. Padding of all pressure areas, care must be taken with the neck during patient transfer and positioning. Temporomandibular joint may be diseased. That will make intubation difficult. Bone stock is often very poor and soft and osteoporotic. So great care is needed to be taken with dislocation because you may end up causing a fracture. A protrusio may be present, and so dislocation is almost impossible, and you'll have to therefore perform a neck cut in situ. Surgical approach, posterior approach is a good option. Direct anterior approach can be used. Avoid the transtrochanteric approach because of the risk of non-union. There's no great advantage using a hard hinge approach for the rheumatoid patient unless it's your set standard approach, and performing another different approach would mean that you're perhaps likely to encounter more complications. The blood loss in these patients are higher due to the inflammation of the disease process. There's a higher infection rate, which has been estimated at around double the standard rate, and there's an increased dislocation rate. In this situation, have a think about what implant you want to use. Dual motions are a good option, or you may want to consider using a bigger head size. Implant choices. Traditionally, rheumatoid arthritic patients had a cemented total arthroplasty performed. It was thought that osteopenia, contractions, and bony deformity prevented difficulty in reliably obtaining the initial stability necessary for bone ingrowth. The systemic inflammatory disease and anti-rheumatic medications also meant there was a concern that osseointegration didn't occur. High rates of femoral stem subsidence and loosening were reported when they were used in some early series. However, recently the NGR has showed an increased use of uncemented implants for rheumatoid patients, and this may be related to the newer generation of uncemented implants and the fact of performing this surgery in a younger age group, and a concern with wanting biological fixation and the chance for remodeling if needed. Results The Swedish Hip Registry reported higher rates of cemented acetabular loosening in rheumatoid patients compared to osteoarthritis. Recent NGR studies have found no difference in revision rates between cemented and uncemented implants, but what they have found, which is quite striking, was there was a significant increase in the 90-day mortality, 1.1% compared to 0.5%, almost 3 times the incidence. So that's us with rheumatoid arthritis. We'll move on to ankylosing spondylitis. This is a chronic autoimmune inflammatory spondylar arthropathy of unknown etiology. Peripheral joint involvement is less common than spine. Hip joint is involved in 30 to 50% of cases, and bilateral in 50 to 90%. It's a seronegative arthritis, with the rheumatoid factor being negative, and a positive for HLA-B27 in 90% of patients. It affects young men, average age of onset between 15 and 25 years. The orthopedic manifestations include a bilateral sacroiliitis, which can progress onto frank ankylosis. With the spine, there's loss of movements, bamboo spine may be present, kyphotic deformities, and a predisposition to fractures which are difficult to manage and have a high rate of non-union. Other joint involvement includes hips, knees, shoulders, and ankle. There's an episopathy, which is an inflammation of tendon insertions, the tendon Achilles being the most commonly affected. There are many orthopedic facets to this condition. Examiners can focus on 1 or 2 of these for a short case, or a more thorough assessment can form the basis of an intermediate case. There are good clinical signs present with lots to discuss. With a history, the patients usually present with an insidious onset of low back pain and stiffness, chest wall pain, and enphysopathy involving the tendon Achilles or plantar tendons. Occasionally, no pain is present, but there's just increased stiffness of the hip and spine. Ask about posture and gait, as these can be significant issues. The ability to perform activities of daily living and ability to self-care, inquire about this. Non-articular manifestations, again, like rheumatoid, don't forget to ask, particularly about ocular pain and difficulties with chest expansion. Clinical examination of the spine, although the case may be primarily hip, you need to offer to examine the spine, and this will usually be affected with the disease process, and there's signs to be pointed out. And you can't really deal with the hip in isolation. So the patient will probably have a thoracic hyperkyphosis, there'll be flattening of the lumbar lordosis. Patient may have a functionally disabling advanced stoop with limited forward vision, the question mark posture. The spine is stiff with gross restriction of all spinal movement. Offer to perform the wall test and Schrober's test. Usually Schrober's test is a modified Schrober's test, and it's abnormal because of a stiff, painful spine. The examiners may say, we don't want you to do that, concentrate on the hips, but at least you've offered. With hip examination, patient will usually walk slowly. Remember, in the back higher order thinking, is there cervical myelopathy present? Be on the lookout for that. There's usually painful reduced range of movement with a fixed flexion deformity. A big trap and mistake is to say that the Trendelenburg test is positive. This is where you can get a negative Trendelenburg test. The hip is ankylosed. It's a false positive. It won't move. If you examine the hip and you start discussing range of movement, forward flexion, 50 degrees, abduction 20, adduction 20, internal rotation, inflection 10 degrees, and the hip is fused. It's quite a big nail in your coffin. So be aware with ankylosing spondylitis, there's a possibility the hip may be ankylosed. You will have a false negative Trendelenburg test, and you will have no movements in the hip. Discussion may revolve around medical management of ankylosing spondylitis, preoperative anesthetic concerns, how you consent a patient for hip replacement, what approach to use, any technical difficulties encountered at surgery, what implant to use. And the big controversy with patients is when they have coexisting hip and spine involvement is what is the order of surgery if they need surgery. And we'll discuss this later. So consenting for total hip arthroplasty, the surgery itself, if it's done well and successful, will lead to significant reduction in pain and improvement in mobility. Patients with ankylosing spondylitis are at an increased risk of complications, and they have an increased revision rate. And this relates to an altered spinal pelvic biomechanics. From a rigid kyphotic spine, this places increased demands on the hip joint. As the patients are younger and they're more active, they place high demands and stress on the implant, and they many times live long enough to reach the lifespan of the components. And that's why we can see quite a lot of broken implants in this condition. A lot of the older studies showed that there was excessive osteolysis and polyethylene wear, but this was related to conventional polyethylene. So we may find with the highly crossing poly that this is not as big an issue as previously. There is an increased risk of dislocation, and there is an increased risk of periprosthetic infection. Technical difficulties encountered at surgery. The bone quality is poor due to disuse osteopenia. There's an increased risk of fracture, reankylosis, nerve injury, and dislocation. You might want to consider heterotopic ossification prophylaxis. Exposure of an ankylosed hip is difficult. Again, like the rheumatoid hip, you may need to cut in situ. The sciatic nerve is in the ankylosed hip closer to the acetabular wall than normal, so there's increased risk of causing sciatic nerve iatrogenic injury. There is increased risk of implant malpositioning due to the sagittal plane malrotation of the pelvis. A couple of papers have been published recently which looked at the direct anterior approach as a good option for ankylosed patients and in reducing the risk of dislocation. However, the supine position can be difficult with ankylosing spondylitis, just positioning the paper. So the direct anterior approach was performed through a lateral position. Femoral exposure was problematic. These papers were from China, where they've got more extensive experience with the disease process. And so for us to take on performing a direct anterior approach via a lateral position is perhaps more trouble than it's worth, and so that the paper should be looked at with some skepticism. This is a controversial area, whether you perform total hip arthroplasty before or after spinal surgery, and you have to have arguments for and against to be able to present these in a viva situation. I think I like this slide. For anything that's difficult, then this is your get out clause. You need a colleague decision and discussion. This is a complex issue. I would therefore adopt a multidisciplinary team approach. I'd utilize the multidisciplinary team input for a shared decision-making process with the patient. I address the patient individual's problems and expectations from surgery. So that's first thing to say. If you do the total hip arthroplasty before spinal osteotomy fusion, your spinal surgeon will be very happy because they gain a clearer picture of the spinal deformity for proper osteotomy planning. The site and levels of spinal osteotomy are better evaluated. And the elimination of intrinsic hip pain and increased hip range of movement may make the necessity of spinal surgery obsolete. As a hip surgeon, it's more challenging and more difficult before spinal alignment correction. And the hip is prone to component malalignment and malpositioning, and there's an increased risk of dislocation. If I perform total hip arthroplasty after correction of spinal deformity with osteotomy and fusion, the surgery that's undertaken, the positioning of the patient for total hip arthroplasty is easier, and it facilitates the replication of the pelvic positioning seen in the AP radiographs, which I would be using to template the components. But the correction of spinal alignment before total hip arthroplasty runs the risk of changing the position of the cup, changing the functional position of the acetabular component from a good position to an excessively anteverted orientation, prone to impingement, dislocation, and edge loading. So that would be some concern. We mentioned you get out statement that you would want to use in a viva situation. So let's move on to psoriatic arthritis. This is a mild asymmetrical seronegative spondylopolysynovitis with an erosive destructive arthritis. The sacroiliitis and spondylitis are seen in about 1/3 of patients, and it's similar to that seen in ankylosing spondylitis. It affects about 10% of patients with psoriasis, and patients have HLA-B27 positive in around 50% of cases. The psoriatic arthritis is now been shown to be more aggressive than initially thought many years ago. And it can range from this mild arthralgia to a destructive, erosive, highly disabling disease, which is termed arthritis mutilans. Important characteristic features include asymmetrical joint distribution, involvement of the distal finger joints, this presence of sacroiliitis and spondylitis. There's absence of rheumatoid nodules. The nails demonstrate pitting and fragmentation. The sausages, the digits can sometimes become sausage-shaped. And classically, there is a pencil and cup radiographic deformity. The distal end of the middle phalanx is the pencil in the cup of the distal phalanx. Rheumatoid factor is usually negative. So psoriatic hip arthropathy is uncommon, but it's a major problem. There's not a big series of cases that have gone on to have total hip arthroplasty that have been reported on. It's thought that the development of hip involvement occurs with a patient that's got early onset psoriatic arthropathy, and it's usually associated with rapid destruction of this joint, and its bilateral involvement as well. One thing to not get confused about is that you may have patients who have osteoarthritis with coexistent psoriasis. They're usually over 70 years of age. This is not the same as psoriatic arthritis. The two conditions are very separate. If you have a patient who's presenting earlier with involved hips, think about anti-TNF starting this early to slow down the development of hip synovitis. This is a patient that saw me in clinic that's wanting hip replacement surgery, and we've just got to work up and think about how we can reduce the risks of complications occurring in this type of patient. There's not a big series of psoriatic arthritic patients that have had total hip arthroplasty. It's been poorly studied. The studies that have been published, however, report similar good outcomes to osteoarthritis. Around half of patients are on biologics or non-biologics DMARS, and this will need to be worked. An individualized program of stopping this medication will need to be worked out with the rheumatologists beforehand. The older studies do report an increased risk of infection due to the disease-modifying drugs, but the newer studies are a little bit more mixed in outcome, and some studies suggesting there isn't an increased risk with careful control of the disease process and a multidisciplinary approach. Postoperative infections and impaired wound healing are, however, a concern in psoriatic arthritic patients. and especially those that receive biological agents, methotrexate or cyclosporine. The surgical insult and stress of the procedure leads in many instances to an outbreak or exacerbation of the skin condition. It's recommended not to operate through psoriatic plaques. If there's severe scaly plaques in poorly controlled skin, refer the patient onto the dermatologist for opinion and management. So this patient, in the previous slide, this patient had very poor disease control, and I deferred surgery, saw back in clinic, and when it was under control, then we went ahead with an operation. Moving on to SLE, this is an autoimmune disease characterized by antibodies to nuclear and cytoplasmic antigens. It presents relapsing and remitting. It can have constitutional symptoms, including fatigue, fever, arthralgia, weight changes, musculoskeletal symptoms, dermatological, renal, pulmonary, gastrointestinal, cardiac, and hematological. Excellent functional outcomes for total hip arthroplasty have been reported in these patients. There is, however, an increased risk of infection due to the disease-modifying medications most of these patients are on. More significantly, there's an increased risk of DVTs and pulmonary embolism occurring, and they have a high, significant risk of cardiac complications occurring, especially in younger patients. So there needs to be a multidisciplinary team approach to managing these patients, involving the orthopedic surgeons, anaesthetists, cardiologists, rheumatologists. This is fundamental in order to optimize outcome and reduce the risks of cardiac complications occurring. Overall, they've got a much higher complication rate than rheumatoid arthritis. They've got the highest complication rate of all the inflammatory conditions, because it's autoantibodies, it's an autoimmune condition. It affects many different disease systems within the body, and they've got the highest mortality rate associated with total hip arthroplasty. Moving on to the connective tissue disorders, MARFAN syndrome, it's a variable autosomal dominant disorder of connective tissue. It's caused by mutations in the fibrillin-1 gene. It principally affects the cardiovascular system, eyes, and skeleton. 2 to 3 persons per 10,000 are affected. 25% of cases are spontaneous mutations. Phenotypic features are tall stature, arachnodactyly, disproportionately long and thin limbs, skin striae, and joint laxity. Musculoskeletal abnormalities include the wrist and thumb sign, which is shown in the diagram in the photographs on the slide, pectus serratum excavatum or chest wall asymmetry, hindfoot deformities, severe flat foot, DDH or protrusio of the acetabulum, classically lens dislocation, which we all kind of learn as medical students, increased arm span to height ratio, scoliosis and kyphosis, reduced elbow extension. There is a high incidence of protrusio acetabulum. This is not necessarily associated with severe hip disease, but it does cause decreased hip range of movement. However, in time, the patient will present with hip joint stiffness and progressive limitation in activity secondary to hip joint pain. Patient may demonstrate a waddling gait, reduced range of movement, hip flexure contracture, a pelvic tilt with resultant hyperlordosis of the lumbar spine, and eventually osteophytic changes do occur in the hip. The role of prophylactic procedures such as triradiate epiphysiodesis is somewhat controversial. It may be appropriate in some patients, but it's only a small number, and it's usually for severe protrusio. A valgus osteotomy will reduce transverse vector forces across the hip joint. That's driving the femoral head into the acetabulum, and may also be indicated in younger patients, and this may reduce the chances of a patient needing total hip arthroplasty or delay its surgery by around 10 years in some cases. So the hip and Marfan's disease, There's not any large series. It's unusual to go ahead with hip replacement surgery in these patients. They do, however, present medical and surgical challenges. Protrusio will make a cut placement difficult, and we normally need to graft the medial wall to lateralize the component, and we will generally use uncemented implants with screw augmentation in this situation. There's a high risk of complications, including dislocation, infection, loosening, and a need for reoperation. The paper to look at is Journal of Arthroplasty. References are below on the slide. Discussion, you may get involved with semantics, and that's whether the severe protrusio rather than the MARFANs results in a clinical condition requiring total hip arthroplasty. As basically, the hip osteoarthritis may be caused by the development of the protrusio itself, or may just be another manifestation of deficient fibrin in the cartilage or osseous tissues in patients with Marfan syndrome. Finally, we move on to EHLERS-DANLOS syndrome. This is a heterogeneous connective tissue disorder due to abnormal collagen with specific molecular defects in type 3 and type 5 collagen. There are many different subtypes and variations in severity, 6 at least that I've come across in various textbooks. And it's classically characterized by skin hyperextensibility, joint hypermobility affecting both large and small joints, joint dislocation and subluxation, early onset arthritis, vascular fragility, mitral valve prolapse, and healing difficulties. Patient has generalized joint laxity. You diagnose this using the Bateman score, so be quite clear about performing the Bateman scoring assessment. You may be asked this in your clinicals. The skin is hyperextensile and soft. It's prone to severe atrophic scarring and hemodesmin deposition, especially over the skins and extensor surfaces. Easy bruising is a hallmark of classic EHLERS-DANLOS syndrome. So management, definitely conservative if possible, and have planned physiotherapy regimes worked out. Competitive activity should be avoided. The joint hypermobility is usually managed by rheumatologists. Surgery should only be considered as a last resort, and the patient again should be managed in a multidisciplinary fashion. Hip pain is common. The hypermobility causes increased stresses on the hip joint, and these patients are prone to labral tears, so there's a high number of them that require hip arthroscopy. A large number of patients also complain of iliotibial band syndrome or snapping hip. The patients may mention loud clunking sensations of the iliotibial band subluxating over the greater trochanter, and this may lead to a trochanteric bursitis. It's important to rule out referred pain from the spine in these patients because spinal pain can coexist quite easily in this condition. It's very important to have a preoperative cardiac evaluation before surgery. You order an echo, you need to look for any aortic root dilatation or mitral valve prolapse, which these patients are prone to acquiring. There has been some concerns with the safety of performing epidurals because of the increased risk of bleeding. The older studies suggest increased risk of bleeding. Newer studies are a bit equivocal. Care is needed when moving and transferring the patient from the theatre because the soft tissues are easily bruised. Intramuscular injections should be avoided because it can cause excessive bruising. Local anesthetic nerve blocks don't always work. Because of this poor skin healing and scarring, it's recommended that clips should be avoided in these patients, and subcuticular sutures for skin closure should be used. You need a tension-free closure of the wound. And just in practical terms, schedule extra operating time for these patients. Avoid putting them last on the list. You don't want a hurried closure to avoid the theatre overload with these patients, but you want to have just a careful closure, tension-free, avoid clips. And finally, post-operatively, avoid aggressive regimes where lots of range of movement exercises are performed, because you want to avoid stretching out repaired or reconstructed tissue because they're at risk of failing. That's me. I hope you gain a little bit of help with planning for an arthritic case or connective tissue disorder that you may come across, either in a clinical examination or probably more likely a Viva type scenario. Thanking you.